Welcome to session 3, called Best EP Practices for the Future. PFA should not be performed in all heart failure patients with atrial fibrillation. For our presentation, we're delighted to be joined by Dr. Doug Packer from Marrouche. Welcome. Before we hand over to Doug, let's meet our expert panel. Welcome Dr. Amin Al-Ahmad from Austin and Dr. Nassir Marrouche from New Orleans. Doug, over to you.
Thank you very much. It's good to be here with you and the other members on the team. I'm going to be talking about best EP practices for the future, but I've broadened this a little bit to look at drug and ablative treatment for AF, outcomes and complications. So now, if my slide can be advanced, I don't have the pointers. Here's my disclosure. The top part is advisory boards. Second is things like grants, and the bottom is intellectual property. So we're going to start here with what's the art? We want to be able to deal with atrial fibrillation on all fronts. Sometimes atrial fibrillation looks like Chagall, and sometimes it looks like Monet, and sometimes it looks like Leonardo da Vinci. But we're trying to go from there to the next slide and have a pretty good idea of what are we going to do with this. We're talking about integrated care for atrial fibrillation, and you can see that this involves a family. There are primary care physicians and dietitians, and the AF patient right in the middle of it. And at the end of the day, we could view everything about atrial fibrillation as being contained in a 4-pillar site. Next. So there's a number of things that have to happen in order to make this atrial fibrillation business work. You have to look at an aggressive risk factor management, dealing with weight management and exercise and hyperlipidemia and obstructive sleep apnea and hypertension and diabetes. And just the very next slide, nature of atrial fibrillation its own. So one of the things, if we're looking at 4 pillars and it's rate control versus rhythm control, and it's different kinds for different kinds of patients, here I'm simply showing you the typical drugs up in the upper left-hand corner. Amiodarone, sotalol, and dofetilide, and over the right-hand corner is the class 1, whereas the others were 3. So disopyramide, quinidine, propofenone, and flecainide. And then there are a whole bunch of different ones that are coming down. So what's the point of all this? Was the same as the next slide. So here we're saying, okay, you just looked at everything we needed to know about rate control. This is rhythm control, maintenance. If you don't have heart disease on the left, and you're looking at flecainide, propofenone, or sotalol, then you could use amiodarone and dofetilide, but the first-line therapy is up here on the left. Well, why does the first-line therapy change? It changes because of the context. If you have hypertension substantially, then you may be looking at something like, you could use flecainide, propofenone, sotalol, or even amiodarone. You have to be careful with these. Going to the next 4, coronary artery disease, well, I have to be careful now, because so we're looking at dofetilide and sotalol, and perhaps amiodarone. If you have heart failure, maybe it's amiodarone and dofetilide, but the main thing is it's a whole bunch of other drugs like ARNIs and GLPs and SGLT2 inhibitors. And we're going to go to that because at the end of the day, we are looking at the 4 pillars. We've seen that it's affected by, or looking at rate, rhythm, and anticoagulation, but now we've gone through some other things that create issues for us, is that hypertension, the coronary artery disease, and heart failure. But now down at the bottom, you see something else sneaks in as far as treatment for these patients. Next slide. They keep clicking. They keep looking like catheter ablation because that's what I'm going to wind up doing. So what is the big deal as we're looking at 4 pillars of atrial fibrillation treatment? And what is the big deal if we're looking at the turning us to ablation for some reason? We have to look at genotypes, phenotypes, physiologic factors, disease, environment, and anatomy. So all of those now feed in to those 4 pillars we're talking about. And we'll talk about that next. Now, it wasn't bad enough to have 4 pillars of atrial fibrillation treatment. We now have 4 pillars of heart failure if the patient that we're looking at has heart failure. And that really is the thing that I've been thinking about a lot, and Marrouche has been thinking about a lot. If you look at the four pillars of heart failure, there's ARNIs, beta blockers, MRA inhibitors, and SGLT2 inhibitors. There's more than that. There's the GLPs, but the bottom line is we have to deal with all of these. And so for treating atrial fibrillation, we have to treat the underlying problem, and that's heart failure. As we'll see in the next slide, we could talk about PFA, and it should be performed on all heart failure patients with AF. This is something that Nassir and I looked at, but I'm just doing this as a presentation into the four pillars. If we're looking at ablation, then it would require that one proves that PFA should be done in all, and it requires that all heart failure patients should be ablated for AF, or that all AF is ablatable, or that we can even have vascular access. So whether it's PFA or not, if we're making a decision of going from drug therapy to ablative therapy, we move one forward. And we move another one forward. Here, our pyramid collapsed. So the next one. Okay, so let's look at heart failure. You have to understand what the underlying process is. And here, Nassir taught us in CASTLE AF and looked at a primary composite endpoint that ablative patients did much, much better in red than did those in the green or the blue line. And you see that there is a relative risk reduction of 38%, hazard ratio 0.62. So now we've gone from the four pillars of atrial fibrillation into the context, which is the underlying disease, and the four pillars of heart failure, because this now is a HFrEF patient. And HFrEFs need additional consideration above and beyond what we've otherwise said. So if we look at this, it looks to me from the CASTLE AF study that ablation patients are going to do better, and it's going to be appreciable, as we'll see in the next slide. Here now we're looking at all-cause mortality as opposed to the composite, but the bottom line is you get out there at about 36, 48 months, you still are going to see that ablation is going to be better. Now, if you go back to the AFFIRM trial or AF and heart failure, there wasn't really a difference between the kinds of therapies, but there is a difference between ablation and typical conventional therapy. And as we see in the next slide, there are a number of meta-analyses that have been done about catheter fibrillation and atrial fibrillation, and this gives us a broader view than just simply something like PFA. And you can see that there's a difference all the way across here. Here's a number of studies on the left-hand column. Those are up there, and these are mostly looking at HFrEF patients. And then we come down and we look at Cabana and RAFT below. But for the bottom line, there are a lot of these that swing to the left in a positive therapy, and there's some things that are just flat on the line. For heart failure in Cabana, it was a positive trial, but for all comers, it was a midline effect. It wasn't positive, wasn't negative, it was neutral. But we have enough information from the others to at least feel good that in the next slide, we can look at other things that become more important. Now, Nassir did the CASTLE heart failure, and this is looking at not just heart failure, this is looking at those HTX patients who basically had end-stage types of heart failure. But you look at their primary endpoint, and medical therapy had a lot more in the way of issues, whereas the ablation group did very, very well. If you look from death, any cause, ablation group had less events. Medical therapy had a lot more events. And you look at the one on the right, implantation of a left ventricular device, this is part of their endpoints. Ablation just did much, much better. So even in patients who had a substantial problem in looking at their end-stage heart failure, there's more to it than that. So now here in all-cause mortality by the meta-analysis again, you can see that everything is creeping more to the left. It's getting off the line in the center or the neutral. And there's still some trials that didn't show any benefit at all because the 595 confidence intervals are spread so widely. And we'll see that in the next slide. And here, as we're looking at 2-year follow-up, this is from Sones. This is still CASTLE HTX. And even at 2 years, ablation still fared better with fewer event rates than what we'd see with medical therapy. So this is now telling us that if we have patients who have heart failure, HFrEF, they should do pretty well with ablation. As we see in the next slide, one more. So here in the Cabana trial, in a sub-study, these are patients with heart failure. Now, these were different in that most of these were HFpEF, or heart failure with preserved ejection fraction. And even here, ablation did better. HFrEF's always been pretty good in responding to ablation. But now if you look here, there still were a lot more events in the drug therapy. And if you look in the next slide, you'll see that there's a difference. Going back one, you'll see that there's a difference in the overall occurrence of either burden, or in this case, percentage. Ablation patients did phenomenally well. The ones that were drug-treated patients did not do as well. And the next slide tells you that we could then ask the question, well, should it be PFA and not RF? Well, it probably could be either. So I'm not really debating here whether it should be PAF. I'm taking a more four pillar approach to this. Next slide. So this is one of the earliest ones where patients were done, and this is from Vivek Reddy, and it's looking at pulse-field ablation versus thermal ablation. Almost no difference on the left-hand side. In terms of serious or non-serious adverse events on the right-hand side, you can see what they look like, and by the bottom line, you'd say, well, the event rates weren't that bad. You could say with any one of these, there might be a 0.1 or 0.2% mortality, and then strokes and TIA seem to be pretty small, going back to the first study. Now, as we see in the next slide, we're going to have a problem with that, because in other approaches, there are other treatments for heart failure and AF, and it kind of depends on what you're using. Now, this is empagliflozin, again, treatment with this drug, fewer event rates than with placebo. For Nair, there are fewer event rates in the ablative patients than there were in the finerenone patients than in placebo. And finally, on the liver, or dapagliflozin, there still were fewer event rates occurring with the active therapy. So these last 2 or 3 slides are intended to say, with these new heart failure drugs, you can actually drop your event rates. And so that basically means that now we've got 2 sets of treatments. One's ablation, one's heart failure treatment. And the heart failure treatments look pretty good. Now, there's studies in HFrEF that it didn't look quite as good, but most of the ones in HFpEF are looking better in terms of treatment modality. Next slide. So we kind of have to consider this, and in a way, this goes back to the 4 pillars of any treatment. But if you're treating heart failure, it's beta blockers, angiotensin receptor inhibitors, mineralocorticoid agents, that's MLAs, SGLT2 inhibitors, and the semaglutide agents. And we'll see what that is going to do in terms of the numbers of problems of patients that we've got. So next slide. So this is just one of the studies from CAMERA, and this is going back to HFrEF. And the bottom line is these patients, if treated aggressively, then LA volumes decreased and LV stroke volumes increased. And in this case, the change in LA and LV stroke volumes was one of the bits of information that we looked at for HFrEF type patients, that they do better. But we still need to look further. Next slide. Next. So how big of a problem is this that we're looking at with our 4 pillars of heart failure therapy and our 4 pillars of AF ablation therapy? Well, in heart failure patients, there's 5 to 6 million right now in the US. Some of them have a reduced ejection fraction below 50%. Those are the HFrEFs. And you can see how you treat those with heart failure therapy. You go down one more, and this is preserved ejection fraction, HFpEF, and they have EFs of 50 to 60%. So you're treating those how? Next slide. I think we missed one there. Here's a whole bunch of different trials in HFpEF patients with atrial fibrillation. And it shows that the AF prevalence in heart failure studies is going to be about 25 to 30%. What does that mean? The next slide tells us. If you're looking at HFpEF alone, then the mortality rate is going to be 10 to 30% at 5 years. AF alone, 5 to 25. HFpEF and AF is 25 to 60%. So now in looking at both the 4 pillars of drug therapy and the 4 pillars of heart failure therapy, if we throw atrial fibrillation together with heart failure, you have a very significant mortality risk, that 25 to 60%. Next. So what about complications? Well, we need to know about this. So let's go in. And this is kind of a major peri-procedural complication meta-analysis. Now here, mostly they look like they're on the side where everything done with an ablative intervention puts these patients in a much, much better category. There still are some where the 95% confidence intervals go over to the other side. Next. And this is a look at complications rates, say with PFA, because that's kind of the best thing in town right now. In the Manifest 17K study, you can see two figures here. One's looking at PFA, and you can see that for the most part, the event rates are way down there, and they're just not in a situation where you need to worry much. Now, if you're looking at Manifest PF 17K, then there are some other things that come up. And so there are some real complications that can occur. And the numbers here for HFpEF in red are those that are a little bit more problematic than we thought 5 years ago. Next slide. This is looking at 2020 complication rates versus 2025 complication rates. And the bottom line is phrenic nerve injury looks like it is up from 1 to 16%, stroke 2 to 4.4%. Asymptomatic brain injury, that's where you have a little bit of an embolic event, but at the end of the day, it's not that problematic. But now it's up to 34% in at least one study. I think 14 to 18% is more real. Coronary spasm was 1 to 5%, and now it's up to 41%. Atrial esophageal fissure, none. Now maybe up to 0.5%. But now we have to look at all of these references. Where did I get the atrial fibrillation or the atrial esophageal fistula business? Well, someone heard of one. So out there in real life, someone heard of an atrial esophageal fistula. I think we have to be careful in looking at complications in ablation in general and PFA in specific. Next slide. The wide ranges denote a certain amount of uncertainty. So if you look at the difference between 2020 and 2025, the bottom line is the complication rates are probably higher, but they're probably not as high as some of these would say. Next slide. So if I'm going to summarize what I've been trying to say, then the point is this. You are working with patients with atrial fibrillation. And if you look at the 4 pillars of atrial fibrillation therapy, they go through things like drug therapy for rate control, rhythm control, anticoagulation. But we've been more interested in this presentation to look at patients who have heart failure. So the point of a debate over drug versus ablative therapies is still unclear, but I think ablation's winning. In additional summary, ablation has worked very well for HFrEF patients, including end stagers. PFA may or may not be the right option for everybody. Cryoballoons may be fine. And if you look at PFA, it might not be any better than RF. And perhaps drugs for heart failure may be enough in patients with AF. It doesn't look like we can ablate them all, because the problem with that is that it's just, there's too many of them. So the issue of incremental complications has to be solved yet. And most patients with heart failure could be benefited by PCA, it should be PFA, but I think this is kind of the last slide, and I just need to review again that we go from a point where we're arguing about drugs to a point where we're arguing about ablation to a point where we argue about PFA better than anything else. But if we're following all of the 4 pillars that we come in contact with, I think it gives us substantial clarity and actually is tipping the balance now in the direction of ablation. So there are 2 major studies coming up for HFpEF ablation. One is Nassir's, Castle HFpEF, and one is ours. It's Cabana heart failure. So those are going to answer some of the residual questions. And at that point, I think we can call it good. So thanks again.
Well, thank you, Doug, for that incredible presentation. I have to say, I heard Nassir's name called about 16 times during the whole talk. So I'm going to start with you, Nassir. Dr. Marrouche's work has been seminal in showing that atrial fibrosis is one of the strongest predictors for AF ablation. So, Nassir, in Castle AF, we saw durable sinus rhythm restoration was key in reverse remodeling. And given early concerns about PFA durability, say in the thick and fibrotic atria, you think PFA is durable enough to produce the same remodeling benefits that we observed in Castle AF for our heart failure patients?
Thank you, Debbie. And Doug, thank you for an extensive presentation. Amin, great to see you. Yes, we're learning a lot, Debbie. As you know, it's been 3 years since we started adopting a PFA into our platforms of AFib ablations. But what we learned is that remodeling, at least initiating or causing a chronic scar on top of fibrotic tissue, seems like using PFA from our first animal experiments on the MRI images we have here is showing that the images are much better and durable. Now, the question is, are we seeing better remodeling at long term? I don't want to answer this question today, to be honest, because we have conflicting data. First of all, we trying to understand when to image that atrium after an ablation procedure using PFA. Is it 4 weeks or 3 months, as we know from the RFA times? We're all agreeing slowly but surely, not only on the blanking period of 4 weeks, but also remodeling. Seems 4 weeks is the time to start looking at the tissue. So we're collecting more data. Your answer is not answered by yes, by black and white. There's a gray zone, and that depends on where do you ablate and how much you ablate outside the pulmonary vein area and the antrum. And that's a caution we giving to everybody when you go outside the pulmonary veins. Whatever you do, you're destroying some of the tissue. Yes, you're keeping the infrastructure of collagen in place, but some vessels remain behind, if any. But the PFA, you're destroying the myocardial cells that contracts. So the PFA ablation allowed us to do more reproducible, objective kind of procedure. That's why Doug's and our trials is going to be different answer than in other trials, because it's been more objective kind of ablation. Nevertheless, I really warn people to ablate too much outside the pulmonary vein areas and antrum unless it's really well needed and established reason for, like fibrosis, mapping. You talked a lot about mapping this meeting, the mapping strategies. There's a target for you to go after. But the empirical ablation, we should really wait until we have enough data, specifically on the left atrial remodeling data. I hope this answered your question.
Yeah, I guess I'll jump to Amin. Amin, you have done extensive work in PFA. Do you feel like HFrEF or persistent AF in HFrEF patients kind of represents a more deeper structural disease? And Nassir talked about we should be very careful about where we take PFA. PFA is considered to be easy, right? It is easy in many hands. Do you feel like the current lesion sets that we can do with the technologies we have is limited for the degree of remodeling that we see in these patients sometimes? How do we re-stratify?
Yeah, first of all, it's really an honor to be with both Nassir and Doug, and it's hard to disagree with either one of them. They're both masters at this. Yeah, I mean, I think there's a lot of reasons why PFA makes sense, right? So one, the procedure is faster, the exposure to anesthesia is shorter. I would argue it's more effective and safer, although I know that there's, we still need more data on that. I think it is tempting to ablate a little more extensively with PFA, and one does need to be cautious about that because it's so easy to ablate. And I think we're still learning with tools like PFA that may have a little bit better durability, in particular if you have good contact, what we can do and what we can't do, and what it truly means to ablate the antrum. So I think those are still things we're learning. From my perspective, I think, you have to sort of think about some of these patients specifically. There's large footprint PFA, which is a large sheath, and some of these patients, it may not be a good idea to put a large sheath in, particularly if they have right-sided elevated pressures. You may cause harm. In addition to that, you also may want to think about the level of hemolysis in some of these patients because some of them are really on the border in terms of their kidneys, and with heart failure, you don't want to hurt their kidneys. So sometimes selection of the correct catheter to use matters. One with less footprint may be smaller catheter. One with less hemolysis might be a more appropriate catheter. But I, in principle, agree with everything both Nassir and Doug said.
Doug, I'm going to ask you one final kind of question. As we enter this PFA era, which is, the whole 3 days, we talked so much about this. What is the one principle that you would tell our audience as EPs we should not compromise when treating HFrEF patients with AF, no matter how fast and simple this technology seems to be?
Yeah. I think it's important to understand that no matter what we do, we're still responsible. We could say, well, we've got a whiz-bang mapping system that just automatically maps everything in the heart. And then we've got a new energy source that's easy to use and anybody can do it. All of these bits of progress in the way we do things doesn't excuse us from using the first principles of electrophysiology. You have to stick with the first principles. If you do that, then you can use technology to help you. You can use technology to get you closer. But with all of these, you have to understand, you have to know when a mapping system or an ablative system is giving you garbage. And frequently it does. So I think that's the most important thing that EPs need to remember. Now, when they do that, then you can line item bring things in. Bring things into your area of expertise or comfort. But, the biggest problem in EP is you have to learn how to learn because everything changes. And as quickly as PFA came in, PFA is going to go. And when it does, if you have not learned how to learn, you're still going to be in trouble because you're going to forget that the first principles of electrophysiology have to prevail.
Well, on that note, I have to say we're out of time. Thanks to Doug for an excellent presentation and to Nassir and Amin for their insights. The next session is on advanced mapping and ICE in PVC ablation, and it starts in just a minute. Hang tight.
Thank you.